deterioration in CCU is a very common phenomena because most of these patients has multiple comorbids to have non-ischemic and ischemic deteriorating conditions. So sometimes we all are really overburdened by the fact that we are all exhausted, so that we feel that we are more deteriorated than the patient. I hope everybody can see my presentation. Yes?
Yes, sir.
All right. So to prevent this burnt out phenomena, we have to be very efficient and know how to scientifically and effectively identify a deteriorating patient. So if you really go to the main chain of survival in ALS, there are 4 areas we should know: early recognition and call for help. So these to prevent a cardiac arrest. So this is the one we are mainly emphasizing today, to identify a patient who's going to cardiac arrest. And then once you detect that patient is in established cardiac arrest, the early CPR is the second chain to survive that patient. So the CPR will buy time until we restart the heart if the heart has a shockable rhythm. So the third chain is early defibrillation.
Shanike, can I interrupt a little bit? Can you go for the presenting mode? You are in the slideshow. You are not in the slideshow.
Yeah.
If you can go to the slideshow.
Yeah.
Not yet we can see the slides.
Just give me a second. Okay. Can you see now?
Yeah, that's great. Yeah. Okay. Now
Right.
we can.
Perfect. So the chain of survival has these 4 components where we have to early recognize a deteriorating patient, then start CPR early defibrillation. And not only that, once the patient resuscitated back, we should not stop things there. The post-resuscitation care is of paramount importance to restore the patient back to his normal physiology. So please remember these 4 key areas of chain of survival from this lecture. So during my next 30 to 40 minutes, I will try to elaborate the 3R, or recognition, response, and real-time intervention of deteriorating patients. Then I would speak a little bit about ABCDE approach, an easy way to identify and examine a deteriorating patient. Then towards the latter part of the presentation, I will tell you how to do an effective handover or how to do effective communication regarding this deteriorating patient into your senior colleagues. And finally, I will touch upon the ALS algorithm and few important aspects where they have highlighted in the ERS in the latest 2021 guidelines. And hopefully we could come into a few recommendations and take-home messages. So what is the purpose of this early warning scores? So as I mentioned, remember these 3R. So when you have the early warning scores, we can recognize these deteriorating patients early. Secondly, we could respond them, or we could have a plan what to do next as a early mechanism. Finally, we have the real-time intervention, or we could act upon the management plan for these patients. So this is a teamwork, of course. You could realize that the recognition part sometimes starts from the nursing officer. So they are the bedside people who always be with the patients and identify these early signs. The response is usually by a senior nurse or a medical officer, and it could hierarchy from the junior most house officer to the senior most consultant, during the escalation ladder. So that is called response. And the real-time intervention is always a teamwork where we do then and there management and care for the things we identify. So remember the 3R of deteriorating patient identification. So why we need to recognize these early warning scores? So these are actually clinical prediction tools. They measure simple vital signs to monitor the patient in hospital health. Usually these are ward setups, but we could apply these to the ambulance setups in a community ambulance services while transferring the patient to the hospital, and sometimes in ICU to daily evaluate their clinical response. So these early warning scores could predict patients' deterioration so that we could come into a scaled warning system so that we can act upon. So usually these are paper-based observation charts, but now we have mobile applications. For example, the MedCalc for all Apple and Android platforms, so that you don't have to write these things. You can just enter the patient's details or vital signs to quickly get an idea about these early warning scores. So this is very important, all of the cardiac critical care teams to be knowledgeable about these early warning scores. So we'll go a little bit about it. So we know that all the patients, including CCUs, ICU, and any critical care setting, there are clinical common encounters. For example, if a patient comes with a heart attack, they will have ischemia as a problem. Sometimes they go into cardiogenic shock or septic shock or mixed cardiogenic and distributive shocks. They will have heart failure to deteriorate them further. Arrhythmia will come into the picture. Sometimes they will have community-acquired or hospital-acquired sepsis. Sometimes we have to take over patients post-surgically, or sometimes patient will have surgical issues during their inpatient stay in CCU. Sometimes underdiagnosed DVT and pulmonary embolism could be very common in our setting because we may not be knowledgeable about it. So these are the common clinical encounters which a patient could easily deteriorate in a CCU setting. So what will happen in a deterioration? They will have deteriorated clinical recovery, so increased stay at the ward and the CCU, going into a peri-arrest and arrest and subsequent death. So we have to identify it very carefully, not to let them go into this vicious cycle. So do we have real clinical evidence for these early warning scores? Are we doing only to satisfy ourselves? No. So there are observational studies showing clearly that usually deteriorating patients will show clinical signs of deterioration at least up to 24 hours prior to a serious clinical event. So these serious clinical event would be increased admissions to the ICU, increased length of hospital stay, cardiac arrest, and death. So before a major event, always remember patient will have this golden 24 hours, definitely showing these signs of deterioration. If you are knowledgeable about it, you could well capture these things. So we learn what are these early warning scores. So very easy to remember, there are several physiological parameters. Remember as the A, B, C, D, E. So from airway and breathing, we have two parameters, the respiratory rate and oxygen saturation. And C is for the circulation, which we measure the heart rate and systolic blood pressure. And D is the disability or level of consciousness. And we usually measure it by the scale AVPU. That is, we check whether the patient is alert, verbally responding, responding only to pain, or unresponsive. But now we have a new parameter, new onset confusion also taken in as a serious problem. And last thing is the temperature, a low or high temperature, body temperature. So we have 6 parameters collectively measuring into these early warning scores. So always remember to evaluate your patient with A, B, C, D, E approach to get these parameters if you think your patient is deteriorating. So this National Early Morning Score is a very common clinical tool we used in most of the countries, including United Kingdom. In fact, it is developed by the Royal College of Physicians, and it incorporated into NICE guidelines, several years ago. And in 2017, it has an updated version called NEWS 2 score, which currently practicing in most of the countries. So what is this scoring system? So as I mentioned, there are several parameters: the respiratory rate, oxygen saturation, supplemental oxygen, temperature, systolic blood pressure, heart rate, and level of consciousness. So we know the normal respiratory rate is 12 to 20. Oxygen saturation should be more than 96. Usually patients don't need any supplemental oxygen. And our temperature is 36.1 to 38. And our systolic blood pressure should be virtually around 110 to 210 according to this scale. And heart rate should be around 51 to 90. And level of consciousness should be alert or A. So when the patient is slowly deteriorating, either they can go into high rates or very low rates. So you don't have to remember each and everything, but you have to know what are the characteristics to flag it as a 3 score or highest score. So remember, a respiratory rate more than 25 and rate less than 8 is a high score. And oxygen saturation less than 91 is taken as a number 3 or highest score. Temperature less than 35 or hypothermia, severe hypothermia, taken as high score. And systolic BP less than 90 or heart rate less than 40 or more than 131 is taken as the highest score. Any patient beyond alertness level, or that is verbal pain responsiveness only or unresponsiveness, is taken as giving 3 marks. The NEWS 2 score added this neurology assessment as confusion, delirium, and dropping GCS also as a highest score. So remember that now it is called as ACVPU than the previous AVPU. So once you calculate the score, taking each component into consideration, you will have a cumulative score. So what is new in the new score is a score of 5 or more, we need urgent clinical alert. So that is, you have to escalate into a senior level, and active exclusion of sepsis also need to be done if your patient's score is more than 5. In NEWS 2 scoring system, there are 2 saturation scales, one for the normal patients and one for the COPD or hypercapnic patients. So they will have a different saturation target. So remember that. And I have already elaborated that the AVPU previous neurological evaluation now had the added component of new onset confusion, disorientation, delirium, or dropping GCS also taken as a score to give 3 marks. So any patient who is newly confused, you should alert yourself that it is a possible deteriorating patient and warn your seniors. So this is the usual paper format, and I will try to break it down for a better understanding. So as I mentioned, the simple approach is A, B, C, D, E. So in airway and breathing, there are 2 components, as I mentioned previously, the respiratory rate and the SpO1 scale. So SpO2 scale 1 is for normal patients, and SpO2 scale 2 is specifically for the hypercapnic patients. So always when you are calculating this score, please try to understand whether this patient is a known previous COPD patient or a normal capnic patient before the illness. So that would guide the patient saturation targets, and that will give the number to each level. So this is a saturation scale 2. So you could understand that the saturation levels are different. For example, they will have a score of 3 if the saturation drops less than 83, and their normal level taken as 88 to 92. So you could see the difference that they have a lower saturation threshold or target. When it comes to the C, we have two things, the pulse and the blood pressure. So I'm not going to reiterate. You can just measure the patient's pulse and blood pressure and just put it into the score. And finally, the level of consciousness and temperature. So after calculating this A, B, C, D, E, we come into conclusion about the score. So there are mainly low risk, medium risk, and high risk scores. The first low risk score is up to 4. And if it is 5 and 6, we call it as a medium score. And if it is 7 or more, we call it a high new score. So please remember, if individual score is 3, for example, if patient has a score of 3 for the neurological deterioration, that itself called as a low to medium risk. So that is a borderline score in between the low and the medium score. So always be vigilant about each parameter, whether it has a score of 3, that is a severe score. So any parameter with a higher score should ring a bell that this patient could be deteriorating on that respective system. For example, neurologically, cardiovascularly, or respiratory wise. Okay. So once you have your scores, you have the opportunity to quickly modify the frequency of observation. So that is usually the nursing officer's job, but always the medical officer's evaluation also come into the picture. But when it escalation protocol is the second important thing, we call it the response, so that we know what to do next. So how frequent you should observe these patients? If the early warning scores less than 4, we can do hourly monitoring for the next 4 hours and see how it goes. If it is totally normal, you can reduce the frequency. But if the score is same, then every 4 hours for the next 24 hours is advisable to monitor. If the new score is 4 or above, then half an hourly monitoring for the first hour, and every hour you reassess the patient. If the score is more than 7, you have to maintain a half an hourly observation or more until patient comes into at least moderate or low new score. So this has highlighted that key messages. And again, a little bit of a summary how to act for these scores. So low risk is 1 to 4. How to respond this is usually the monitoring nurse will tell the senior nursing in charge of that unit about this slowly rising score, so that she can take a decision to increase the frequency of monitoring or escalate into a further care. But if the patient has a medium risk, that is aggregate score 5 to 6, always there is the need to urgently escalate or urgently refer to your clinical team. So this clinical team is usually start from the house officer, then the senior doctors, senior registrars, and consultant, depending on the urgency. A high risk a new score, more than 7, usually it should be directly triaged to the ICU team or the critical care team or the senior most team, like the consultant or a senior registrar, to take the decision. So any patient with 7 or more score, we should be very careful. This is a bit of a summary how to act upon in a situation like this. This is actually Australian algorithm. A mild score, usually the nurse to contact its team leader or the nursing in charge or the matron or sister, then he or she will ask the medical officer to review the patient within the next 30 minutes. If the medical officer is not in a possibility to review this, then they will triage it to the next senior person or the registrar to review within the next 30 minutes. So you can see that this system allows us to be very accountable for the patient. So I think when we have a very accountable system, the healthcare improves and the patient will be in a very safe situation without any neglect for the patient. And if the moderate score, then it to be triaged directly to the senior most one, like a registrar. And if the registrar is not available to review within 30 minutes, ideally this protocol gives the opportunity, the nursing officer, to directly contact the consultant or MET team, which is medical emergency team. So in other countries, we have a medical emergency team, which is mobile. So in any arrest or peri-arrest situation, that team quickly rush to that place and try to resuscitate the patient. So that is still not available in Sri Lanka, but should be evolved in future. If the score is severe, that is more than 7, then directly the reviewing nurse should escalate or call to the medical emergency team or the critical care team or the CCU senior most ones to take the decision. So in this algorithm, you could understand that nothing is going to miss, and quickly within an hour period, or we call it the golden hour of sepsis or golden hour of ischemia, the patient will have a plan how to manage within that hour. So please remember, a deteriorating patient will not see the sunrise in the following day. That is not, we are talking not about 4 to 6 hours after review. We are talking about half an hourly monitoring or maybe reviewing the patient in 1 hour. So please remember, as a take-home message, in a CCU or any critical care setting, the review is very important to be done regularly rather than again reviewing the patient in the morning, right? So there are different early warning scores for the maternal patients, pediatric patients, and newborns. I'm not going to elaborate on that, but remember that there are different scales. For example, if a pregnant mother comes, that these early warning scores are different up to 6 weeks after the postpartum period in a pregnant mother. So it's nice to know these things, that there are different scoring systems for these subpopulations. So now you have listened to me and it's a bit boring now. So we'll come into a case scenario where we'll try to understand a clinical situation where a doctor or medical officer, or it could be a nursing officer, handing over a patient of this kind of a deteriorating patient, right? So we'll listen to that. Please let us know if it is not.
Sir, we can't hear anything, sir.
Can you hear this?
No,
We
sir.
can't hear, sir.
Not yet, sir.
Could you able to hear the voice
yet,
track?
sir.
No.
All right. Right. Just give me a minute.
No.
You can't hear, right? Okay, so I think we are having a technical problem here. So I'll try to so we'll try to listen to that. Just let me know if you can hear it. Can you hear?
No, sir.
No.
All right. Okay. Right. So I think we have a technical issue to hear the clip, right? So I'll just concentrate on the right. So there are situations where the handover is not very perfect, that when you see a deteriorating patient, you quickly get excited and basically call your seniors what to do. So there is a scientific way of doing this handover, and we call it S-bar handover, right? So this is the S-bar handover, and I'm really sorry that I could not play the clips so that you could appreciate a bad handover from a good handover, but I'll try to elaborate about it as we go. So this S-bar is actually a tool originated from US Navy in a war situation where there are a lot of sound and war sounds and everything, so that we have to be very specific about a handover. So this S-bar is, S is for situation, B for background, A for assessment and recommendation.
So can you
Right?
see
You can't see the presentation.
You can't see, but
You
screen?
can't see the presentation.
oh, sorry. Can you see now?
Yes, sir.
Right.
Slide share.
Can you see now?
Yes, sir.
Yes, sir.
Full screen? Right.
Full screen.
Yes, sir.
Okay, so the situation, background, assessment and recommendation is the correct way to hand over a patient. So suppose you are basically having a patient with deteriorating symptoms and you want to escalate or basically get an opinion from your seniors. So to do this without panicking, this is the system you should present it to your seniors. So situation is you introduce yourself that you are so-and-so, the doctor by name, and calling from CCU or ICCU, and you mention the patient name, age, and where the patient is there with the general summary of the new scope. So you could see that Dr. Shanta, one of the doctors, on-call doctors from CCU, I'm calling on to get an opinion regarding Mr. Sirisena, who admitted with inferior MI. Today is day 3, and I'm a bit worried that his news score is getting high, and currently it's 7. His background is he's a diabetic patient who admitted with a 2 days history of pain with a late presentation of inferior MI, and patient was stable up until now. And for the past 2 hours, patient is deteriorating with low blood pressure and tachycardia. Then we go to the assessment of what you think about the patient. So in assessment, you can say that, so I think this patient is maybe having right ventricular infarction in the background of inferior MI. I did a ECG and it shows right ventricle, or maybe I want to do a ECG and give some fluids. What's your opinion about it? So recommendation also comes with your presentation. So remember that this situation, background, assessment and recommendation is very important to identify the patient from the senior end. And that is important to identify to you to get an idea about the patient. So always try to, when you encounter a deteriorating patient, remember the A, B, C, D, E approach, get a new score, and how to present it to your seniors in the S-bar communication tool. So in the recommendation section, you can ask, do you want me to do anything else? Like a focus echo, doing an ABG, put a central line. So that recommendation you can ask from the senior, or you can say that you have already done that. So you can see that in the right hand side, there is an area to write these everything. So in most of the health systems, including the NHS in UK, we have a compulsory obligation to write these things and document these things. So I feel that in Sri Lanka, sometimes we don't do this because we have a very high patient load, but this will be a very useful way to evaluate and cross-check back if something goes wrong. So then once you hand over a deteriorating patient into your seniors, or once your nurse hand over a patient to you as the on-call doctor about a deteriorating patient, what would you do? So again, it's a very easy approach. Maybe the patient is in peri-arrest situation, or maybe patient is in slowly deteriorating situation. Always evaluate the patient in a very scientific and a methodical manner. That is A, B, C, D, E. So we'll slowly go and see what is this A, B, C, D, E. So in A, we just go and talk to the patient and get an idea whether the patient could talk with you. So if patient can talk, that means patient has a patent airway. If patient can't talk and having a lot of noisy breathing, or maybe a lot of secretion, then you should always open the airway, do some suction, secure the airway, give oxygen in that approach. So remember, this ABCD approach is not only an examination approach, it is at the same time real-time intervention approach. You can see that if once you hear that patient is having a noisy breathing and a lot of secretion, you quickly ask the nursing officer or yourself to open the airway, suck the secretion, secure the airway, and give oxygen. Then we go to the B, or breathing. Then if you suspect that patient is very drowsy and you can't really see that patient is breathing, then it is a peri-arrest situation. Then you have to look, listen, and feel the patient. So experienced life support provider will quickly go to the patient and shake the patient and see whether the patient is only drowsy, or if it is not moving, then he will look whether he's breathing, quickly listen whether he's breathing, and feel it to your face whether you could feel the breathing. And if not, a pulse to quickly check and call a cardiac arrest call. So in this approach, if the patient is breathing, you can always get a respiratory rate evaluation. You can evaluate for subcutaneous emphysema, auscultate for added sounds and breath sounds, whether the chest is symmetrically moving or not, check the trachea, whether it's deviated or not. And also you can see whether the patient is cyanotic or having elevated JVP. So this breathing is a very important thing. If you find abnormality, you have to exclude pneumothorax sometimes, you have to start inhalation therapy, or sometimes non-invasive ventilation or ventilation to make sufficient oxygenation to the patient. So this breathing part is very important. Then when we go to the C, we evaluate the heart rate, blood pressure. You quickly evaluate the capillary refilling time and see whether the patient is pale or not. And if patient pale, just quickly evaluate the generalized body for bleeding diathesis, hematuria, maybe melena, and quickly take the blood samples, establish an IV access or central access, and be ready to deliver the drugs, transfusion, fluid, or inotropes, right? So again, I want to elaborate that this ABCDE approach is not only an examination, a real-time intervention. So now you know that the importance of the 3R, the recognition by the early warning score, the response you do by escalating it, and the real-time intervention while examining the patient. Then the final D and E. So you just talk to the patient whether he's alert already or whether only alert to the verbal stimulus or pain or unresponsiveness. And any patient who's alert but confused or delirious should flag into a score of 3, where you have to escalate into a at least moderate risk category, right? So in this situation, you take the blood glucose evaluation just to exclude hypoglycemia, do a basic neurological examination, and maybe if in a conditions where acute admission, a toxicological examination if you suspect a poisoning. Finally, a head-to-toe examination to look for temperature, injuries, edema, scars, kinds of drug abuse or skin changes. For example, cellulitis could be well hidden under the body during mainly on the pressure areas if you are not really looking into it. So the ABCDE approach to examine a deteriorating patient, real-time intervention, I have explained in this slides. So what would you do if you suspect a in-hospital peri-arrest situation? As I mentioned, you just check for signs of life. So you just talk to the patient, shake the patient. If no signs of life, if you are in a doubt, always call a cardiac arrest call. We call it call and collect. So you call somebody to call a cardiac arrest, and team should inform the critical care team or your subsequent team to rush to the place, and you collect the resuscitation equipments quickly, maybe a nursing officer or attendant available. High quality CPR, early defibrillation, and subsequently, if the patient is recovered, then a post-resuscitation care should be done. And in that handover also, when you want to hand over this patient into a different caretaker, for example, this patient maybe need tube and subsequent ICU stay in a ventilating setting in ICU. So then you have to hand over this patient by that SBAR communication approach, right? If the patient is not arrested, then it's the ABCD approach, and try to correct each and every component then and there to basically take the patient recover again, right? So the final part of the lecture, I would like to reiterate about few ALS protocol top messages. So remember, number one, the topmost message is high quality chest compressions with minimal interruptions, early defibrillation, and treatment of reversible causes remain the priority. So from 2020 to 21, they again and again highlight that you should not stop the chest compression, even in the absence of an airway helper. So remember that your chest compressions is squeezing the lungs into a situation where it sucks the air. So if you don't have anybody, if you are the only person, just concentrate on the chest compressions. You don't have to worry about the airway until there is more support. And you don't interrupt. For example, after seeing the rhythm of a VF, until they are ready with the pads and everything, you have to continue CPR. Don't stop the CPR until they are ready and shocked. Only you take away from the patient if they are ready with the shock, and inform to get away from the patient and oxygen to be off. So remember, high quality, uninterrupted chest compression is a hallmark, and early defibrillation. Then we have to pre-monitoring signs and symptoms often occur before cardiac arrest in or out of hospital. This is the one I'm telling again and again. Usually these patients will show signs of deterioration 24 hours before a major event. So always, if you monitor these patients very carefully, you can catch them early. Use a basic advanced life airway technique depending on the availability. So you don't have to always put a ET tube or endotracheal intubate these patients in a ALS. So if the airway is patent, you just concentrate on the chest compressions by giving a bag and mask ventilation, or maybe to put a guadal or oral airway to the maximum level until a much capable person is available to do a ET intubation. So my experience is sometimes we are very over enthusiastic to put the ET tube, and sometimes we stop the CPR until they put the ET tube, and we waste so many minutes of precious time to perfuse the brain and organs. So please remember, use a basic technique to keep the airway open until advanced airway support team is available. We have to use adrenaline early for non-shockable cardiac arrest. So remember, the adrenaline is used for non-shockable very early. For example, if you find that he's having pulseless electric activity, you have to use the adrenaline within the first cycle. We use the adrenaline in the third cycle, basically in a shockable rhythm like VT or VF, and use every 3 to 5 minutes thereafter. So using adrenaline in early, if it is pulseless electric activity, and shockable rhythm, we use at the third cycle, right? This will give us the opportunity to learn the algorithm. So you know that the CPR is 30 to 2. Usually the heart rate is keep around 100 to 120. And you should go 5 to 6 centimeters in the depth. And remember, when you give the CPR, please allow the chest wall to recoil back. So sometimes I feel that you give the CPR in a very vigorous manner, that you are forcefully preventing the recoil of the chest wall. So always give the CPR and let the chest to recoil back. A very important thing in the technique, right? And you assess the rhythm. And if it is shockable, you give the shock and resume chest compressions for 2 minutes. So remember, after the shock, you don't wait until you see the rhythm or anything in the monitor. You just take over the CPR again and continue for 2 minutes and then see the rhythm. So always that highlights the importance of uninterrupted chest compression. So remember, very important, you do not stop the chest compressions. You just shock, take over the CPR for 2 minutes and then see the rhythm, all right? So non-shockable rhythm, it's a very easy algorithm. You 2 minutes, again, see if it is non-shockable. Again, you continue CPR for 2 minutes and then go on. So at the end, you give adrenaline every 3 to 5 minutes, and amiodarone is after the third shock. So if the patient is not recovering well, then you have to see whether there are any reversible causes. So there are 4 H's and 4 T's in resuscitation. So remember the 4H: hypoxia, hypothermia, hypovolemia, and hyperkalemia are reversible things. So always remember whether you have excluded this as a team member who is doing the resuscitation. The 4 T's are the tamponade, cardiac tamponade, tension pneumothorax, thrombosis, and toxins, right? So remember your 4 H's and 4 T's. So we approach the final part of the lecture, and the recommendations are we all need education and training for this critical care and cardiac critical care to train these doctors, all of you, about these early warning scores, how to be knowledgeable about monitoring, that is recognition, how to respond and escalate, and how to manage these patients in different scenarios. And ALS training and revalidation is of paramount importance for all the cardiac doctors. They should know how to resuscitate a patient. In Sri Lanka, still there are no protocols or escalation pathway to incorporate new scores into national guidelines. Some centers, they try to incorporate, but if we think from the patient point of view and not as extra burden of work, I think you will understand if your mother or father admitted to a hospital and if the hospital is not geared to revive the patient in a more scientific manner, what will happen to the patients? So if you think in that line, you will understand why we should have a Sri Lanka national guidelines to incorporate an early warning scoring system. Still in Sri Lanka, we don't have a medical emergency team concept. All the wards will have their own resuscitation team. So maybe the team at night in the ward. But remember, if there is a very highly skilled, highly trained emergency team in the hospital who can come quickly within 1 or 2 minutes to a place where they could effectively do a cardiac resuscitation, the patient survival may go really high. So I think the concept of medical emergency team or cardiac arrest team in OFF hours specifically is a very important concept to consider in Sri Lanka. And as this is the IT era, we don't need paper formats. We can develop a software platform for early warning scores and implement in general ward setting in Sri Lanka. So the take-home message for those who are sleeping is remember your 3R to recognize, response, and real-time management these critically ill patients, not only in CCUs, but all the critical care settings. You know now what is news score ring system, and remember the mobile app, the MedCalc or any other application, so that you have it in your smartphone to use it. You currently knowledgeable about the situation, background, assessment, and recommendation or SBAR communication tool, so that you know exactly what to tell it to your senior registrar or your consultant about your patient. And now you know if a patient is deteriorating and the nursing officer tell you about it, what exactly to do to evaluate the patient in A, B, C, D, E approach, to examine the patient and to do at the same time, real-time intervention. I have elaborated the important aspect of ALS and some technical aspects of the ERS 2021 guidelines. And always remember the reversible 4 H's and 4 T's if the patient is very resistant to recover back. And the future for the Sri Lanka would be the SLED system, or Sri Lanka Early Warning Data System for all hospitals, which is a cloud-based or smartphone-based common software platform, which is pretty easy to develop in the Sri Lankan context if you are really geared to do that. So this will conclude our today's lecture and the final lecture. And please remember the chain of survival, early recognition, early CPR, early defibrillation, and post-resuscitation care as the chain of survival for deteriorating patients. So I will do a single MCQ as this is a final lecture, just to elaborate what are the types of MCQs you will get. So this is a 62-year-old man after a late anterior STEMI had a cardiac arrest, and you are the on-call doctor in CCU, and notice that the initial rhythm is pulseless electrical activity, or PEA. According to the ALS guidelines, which is the single most appropriate step in the management. Can you see the MCQ?
Yes, sir.
So what do you think? What do you think about the answer?
Yes,
Give
sir.
amiodarone 300 milligram IV after the first shock.
No.
What do you think?
No.
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 Right. So after which cycle you give?
Third
The 2
cycle.
cycles, the third.
Yes.
No.
What about the second statement? Give adrenaline 1 milligram IV early and every 3 to 5 minutes.
That's true.
Yes. True.
Yes, that looks true, right? Yes, because this is a pulseless electric activity, so you have to give it as early as possible. I mean, if you want to give in a PEA, early as possible. But if it is a shockable rhythm, basically, you give it in the third cycle and every 3 to 5 minutes after that. What about the number C? Chest compression should be performed at 80 to 100 per minute.
No.
No.
What is the rate?
160.
Yes, so 100 to 120 would be the rough thing, 5 to 6 centimeters down, and let the chest to recoil back, right? Atropine 600 milligram IV should be given at start. I mean, it's quite common, isn't it? I mean, when it really comes to the resuscitation, sometimes we see that already the atropine is given, right? It's not right, right? Yes. So it's not in the ALS arrest guidelines. So, but in the bradycardia, yes, you can give atropine, but not situation or pulse activity. Each CPR cycle should be 3 minutes. That is wrong. It should be 2 minutes, right? So if it is best of 5, I think B should be the answer, right? So very good. So this will conclude our lecture today. So I think I have already distributed the reading materials. So please remember how to recognize, response, and real-time manage these deteriorating patients. Be knowledgeable about the NEWS2 scoring system and try to incorporate it into your practice. Always practice to hand over a patient to your colleague and your seniors, or maybe to a different clinical setting like ICU, ward to ICU, by SBAR approach. And remember ABCD approach to evaluate a deteriorating patient and manage at the same time. And be sufficient with your ALS skills. And always, I think the future for Sri Lanka would be early warning scoring system for these ward setups and a software platform. Thank you very much. So if you have any questions, I'm happy to answer, and I thank Dr. Guruparan and the SLCC on giving me this opportunity to conclude the 15 lecture series today, and we are looking forward for the evaluation in near future. I'm happy to answer any questions you have in today's lecture.
Hello, sir. So regarding that NEWS2 score system, that have they considered about the Eisenmenger syndrome? That because they have the low saturation, and if they improve the saturation, the score is that according to the COPD, that is the bad point of the patient. But considering the Eisenmengers, it is the good point. So with that score system, it's a different, right?
Yes, so it is Eisenmenger's is exactly like the COPD because they are hypercapnic patient subpopulation, isn't it? They will never have normal saturation levels in Eisenmenger's. So always, I mean, in these guidelines, they don't have Eisenmenger specific evaluation, but always they will be taken into the SPO2 scale 2, where we know that they have a different scoring system. So this is the SPO scale 2. You can see that the normal level is 88 to 92, right? And even more than 93 also taken as normal, but 88 to 92 also taken as normal. Can you see? So this will give the Eisenmenger patient to fit into normal if it is within 88 to 92. You are worried if they are less than 88 and very worried if they are less than 83.
83. Okay, so thank you.
Okay.
Excuse me, sir. For Sri Lanka, sir, as a cause of cardiac arrest, hypothermia, is it a common cause, sir?
I don't think. I mean, UK, it's a very common cause. I mean, almost all the patients, they have hypothermia on admission. But in Sri Lankan context, I think it's the other way around. Sometimes you may have heat strokes, or sometimes we are a temperate country, Sri Lanka. So always both are, I mean, likely situations clinically. For example, very visual patient found on side of a road in the cold night, like those situations, you have to always measure their temperature. If they are really hypothermic, scaled graded temperature recovery is the way forward. So always remember, once you recover the patient from arrest, always measure the temperature. And if they are hypothermic, it's likely to be hypothermic. Graded warming and graded scale temperature to their normal physiological level is paramount important, because that is resuscitation or achieving ROSC is not the only thing. After that, you have a multiple avenues like golden hour of sepsis, golden hour of excluding a STEMI to go to the cath lab, golden hour of inotrope support, and golden hour to make them normothermic to prevent the recurrent cardiac arrest. So remember, the last part of the chain also very important. This is very easy. If you have this in your head, you don't take the patient as a cardiac patient or respiratory patient. You take the patient as a clinical situation rather than ischemic patient or septic patient. So always you will not miss if you stick to this chain of survival principles.
Thank you, sir.
Sir, at what time we can give amiodarone in pulseless electrical activity in non-shockable rhythm?
So in non-shockable rhythm, there is no place. So, we give amiodarone to VT or broad complex tachycardia, right? We usually don't give it for narrow complex tachycardia or pulseless electrical activity. So PEE arrest means the heart is not basically pumping at all, or it's a flat line, right? So you have to continue the CPR until it captures the rhythm, right? So if you have a rhythm secondly, for example, if a PE convert into a VF or VT, then you take it as a fresh case and then start your algorithm again so that you can give amiodarone at that point, but not in PA.
Thank you.
So repeated the shockable rhythms, how many times you can give amiodarone?
That is, good question. Now, initially, we give 300. And if you see a shockable rhythm again, like a VT storm, then you can load the patient up to 1.2. So you give the 300 and load 900. And if it is still resistant, you can again load the patient. So you can load the patient twice, up to 1.2, twice. And if it is resistant, then a lignocaine infusion would be one way to tackle. So it's a VT. Then it's out of the normal protocol. You go for resistant VT VF protocol, right?
So lignocaine infusion or the bolus following the infusion?
You can give a bolus, but infusion is the way forward. The only problem in Sri Lankan setting is we don't have a cardiac specific lignocaine. So it's a normal lignocaine available in most of the centers, so that we have to take it, dilute it, and give it according to the dosage.
Okay, so thank you.
So in the new guidelines, is there a place for IV atropine?
New ALS guidelines, you mean, right?
Yes.
No. So atropine is not in the arrest situation. So if your heart is stopped, then you don't give atropine. It is the ALS algorithm where you have to start the CPR by time and do it until the heart recovers. But in bradycardia guidelines, yes, atropine is there. So if patient has a bradycardia less than 40 or high degree of heart block, yes, there is a place for atropine, but not in the ALS arrest algorithm.
Okay, so thank you.
Thank you, Shanike, for coming and giving this lecture from UK.